message which comes through is, one, you have to respect the consumer or the patient. You cannot treat this patient as a kind of subordinate, someone who has inferior knowledge to you. You have to respect the patient, you have to respect the capacity of the patient to understand what you tell them, and it is your responsibility to bring that level of communication down to a level which they can understand. It could be a procedure, it could be a medication, it could be about a complication, it could be any aspect of care which covers the entire spectrum to pre-hospital, intra-hospital, post-hospital and outpatient care. They deserve to know this. And the message which I would like to give is, today, if you are a consumer and you decided to invest your hard-earned money, how many times do you ask your financial advisor questions? How many doubts do you have? How many answers do you want before you put 1 rupee into that investment product? You buy insurance, how many questions do you ask the person who is selling you insurance? You expect answers. You expect to be treated as an equal even though you are not from the financial services. How much of research do you do before you select a college admission to a particular program? How many questions do you ask? How many answers do you expect? Do you expect it to be treated as an equal in answers? So I think we expect a tremendous amount of information as doctors, or as Dr. Stanford said, healthcare providers. When we seek services from other service industries, why cannot the patient expect the same from you? We have even now a scenario in tertiary and quaternary care hospitals where you have quality improvement, where there will be a major surgical procedure. The consultant may explain the procedure, but probably it is going to be the senior resident or the junior resident who is going to go and take the consent. Do you know, at the University of Toronto, I have a personal example, we would do 12 to 14 cardiac surgeries a day. And 14 of these cardiac surgeries are going to be on a Monday. It was mandatory in the institute that every single consultant and anesthesiologist who is going to be involved in that procedure has to come in on a Sunday, take the informed consent, explain. It is not left to junior residents. That is the importance of consent. That is the importance of the senior physician. How many times do we do it in our Indian hospitals? It's probably the nurse, the junior medical officer who has joined, or the senior resident. The consultant would have spoken about this procedure probably when they saw the patient in the outpatient 2 weeks ago for about 2 minutes. So this is the current scenario, and this is happening because we somehow still do not respect the patient's right to know. We invest time and everybody talks about quality time. Everybody talks about relationships are built around quality time. Family relationships, marriages, relationships between students and faculty is built around quality time. What happened to the doctor-patient relationship? Where is the quality time? Everyone says if you spend quality time, you are going to build a solid relationship and that is going to be stable. That is the one thing we do not do. How many times do we have the courage to tell our wives or our children that you know nothing about this, just follow what I am doing? Do we do it? We don't. Because we respect them. This is the need of the hour in patient empowerment and patient safety. And we have some distance to travel. However busy we are, we do not have the option of not communicating with patients. We will have to find mechanisms. I do not have time is not an answer. It is not an acceptable answer in this day and age. And I like to focus on one point. We all take consent for surgical procedures, invasive procedures. As Mr. Raja said, When you are starting an antibiotic in the critical care unit which is going to cost 20,000 rupees a day, do you take consent of the patient? We don't. We say, this is the medication which is the best for you. Medications are an equally powerful tool in your armamentarium, and we explain nothing about medications to patients. We've come a little distance in explaining about surgical procedures. We're not there yet. But this is another aspect which we all have to think about, that you also have a responsibility to give detailed explanations, particularly about very complex medicines, very expensive medicines, which are going to be used. You have a responsibility to explain to the patient about this. It's not just about surgery. It's not just about anesthesia consent. It's not just about invasive procedures. It is about medications also. And I repeat again, mental trauma to patients is decreased to a significant effect, where you have to talk about pricing of these services. When you apply to an educational institute, you ask every little piece about the pricing. When you go for an investment product, you ask. Here, they may ask and they're brushed aside, or there is no transparency and nothing comes through. So this is my observation based on the input of 3 speakers, and now we are running reasonably on time, 11:30. I think we can spend about 10 minutes to 12 minutes on questions from the floor to the panelists.
Good evening everyone. Myself Pradanya. Sir, we talked about increasing the patient-doctor relationship. My question is, in India there is a huge population of uneducated people, and especially more people who are coming from rural areas. So those people are not even educated and not even very concerned about their health issues. So my question is, how can we increase our reach, and how can we make those people concerned and educated about their health? Say for suppose, even the directions and indications on the listers are in English, so uneducated people can't even read it. So these are some very basic loopholes in our health department. So what I want to ask is, how can we make those people educated and concerned about their health?
What have you just done? You've asked a question, isn't that right? You've spoken. So I presume if they can't read, at least somebody can speak to them. So I'm not the expert on what happens in India or with the uneducated people, but you have to find a way. Visual posters, demonstrating, discussing with people, getting other patients who have had similar procedures, etc., to talk with them. Trying to get better school education. It's not the whole thing in terms of empowerment. The attitude towards it and the development that has come from America, Europe, etc., is very dependent on having a good basic level of education. If it doesn't apply in India, you have to approach the basis first of all. You can only do your best. We as healthcare workers can't do everything. We're not ordinarily educated, we're not schooled, we're not, etc. But you have to push for that. That would be my...
Absolutely. This again, young man, comes to the question of respect. You can always communicate even to an illiterate patient. Do not confuse illiteracy with intelligence quotient. You have to respect the person who is opposite you as having a basic level of intelligence. Intelligence need not necessarily mean literacy. You can have people who are intelligent but they're not literate. I had a very intelligent grandmother who had never gone to school. Could she not understand something which if I went down to that level and told her she could understand? Yes. As Dr. Sanford says, the onus is on us to take it down to that level, and they will understand, because illiteracy should not be equated to a lack of intelligence. Everyone has the intelligence to understand. I believe in that. It's a question of how you put it across. So if I take this entire set of people here and I start talking to you about how we do a merger and acquisition and how we do a due diligence and how we decide where money has to be invested, am I to assume that because you do not know about this, you are not intelligent enough to understand it? I can teach you. Similarly, you can teach the patients. The onus is on you to understand, bring it down to a level and put it across to them. And trust me, that is not going to happen through blister packs. It's essentially going to happen through what Dr. Stanford said, a one-to-one communication. And it can be done for anyone. I do not believe that it cannot be conveyed. It can be conveyed through conversation if they are not able to read or they are not able to write. But you certainly can convey whatever you want.
And I would just make a brief addition to that. There's a study recently that showed that 6-year-old children have better knowledge of the internet and the game mechanism than 46-year-old people. The study has shown that. Now those children haven't been to grammar school, they haven't been educated, they haven't, they're still at a young level, but they can do it. Because, as Dr. Ram said, many of them have the intelligence to do it. It's the brightness, it's not the knowledge base, it's the ability to use information. So if you give them information, they will utilize it to the greatest ability that they have.
Good morning, sir. Good morning, ma'am. Thank you for the wonderful presentation. I am Akanksha Adhikatti from Symbiosis Institute of Health Sciences. My question is that in rural India, there are hardly any doctors who can treat patients. There is so much of there's a dearth of doctors there. So then how can you try and make them interact with the patients when there are so few doctors hardly available for treating the patients? And especially in rural areas, I'm from Mumbai and my parents work in Nirubai Ambani Hospital at Panvel, Navi Mumbai. So I have seen that there are not enough doctors to treat patients. So there is no question of time spending time with the patients. So how do we deal with that?
I think you brought up a very good point, and we thank you for that. Stages of healthcare delivery will go through various levels of evolution. So we in our country and also all over the world, there is a shortage of healthcare professionals, and the government and policymakers are trying to address that. So access to, your question is around, they don't even have basic access to healthcare services. That will change. We are getting better from where we were 10 years down the line. And obviously once access is there, then there has to be a proper equitable workload on our doctors, because now even if patients have access, our doctors and nurses are overworked. They're trying their best to meet the needs of the patients, and therefore they see many more patients than they can or they need to do justice. So that will evolve. I think there are two things that need to be. One is a governmental, social, cultural issue of educating people to improve their health and take health in their own hands. And that is outside of the healthcare domain. Even at school children level, people should be educated to be healthy, to take care of hygiene, toiletry uses, good nutrition, following their medications, first aid. So I think 90% of the healthcare problems of the country have to be solved outside of the healthcare domain. And certain illnesses can also be managed through empowering the normal citizens to take care. Prevention as well as early illness management, say at the primary care level. coming in for immunizations, taking care of day-to-day illnesses, chronic illnesses, as our colleagues have also brought up. That's a huge opportunity. And when patients come to us with serious illnesses, say cancer or heart surgery, I don't think any amount of patient education will ever fill the gap that a doctor can in deciding the technical aspects, the risks, and it has to be a balance between trusting the healthcare team to do what's best for you, but you know what they are doing. So decision making may not be 100% in the hands of the patient, because they will never be 100% power to decide whether I should take chemotherapy or I should do this surgery over the other. It's too technical a subject. So it's going to be evolutionary. We'll never reach 100% target. The horizon will keep getting better and better and moving forward.
To answer your question to the next level, the way the West has worked around it and the way we are working around it in our country is, the central piece you brought out was there are not enough doctors to disseminate information. Am I correct? This is something which has been dealt with, and that is why abroad you have nurse practitioners, you have diabetic nurse educators, we have actually nurse educators for cardiac surgery who can explain preoperative, postoperative issues. So you need not necessarily have all this information being disseminated by a doctor. You can take it down the value chain, and there are people in the delivery chain who can give 90% of this information. Today, a load in a diabetic clinic is to a large extent taken by the nurse educators. They explain about short-acting, long-acting insulin, how to take it subcutaneously, what to do. So that level of decentralization is actually happening in our country. But as always, you see, we have white papers and we have things which look fantastic on paper. But what you're talking about is actually something which is supposed to be done by an ASHA. They are the engines to create awareness in the deep rural areas. It's another matter, are they being trained enough? Are they being educated enough to disseminate this information in the deep rural areas which you're talking about? It need not necessarily be a doctor. You can have these people disseminating information.
Good morning. I'm Dr. Kansha Sood from the ISMI University. My question is, as you have already emphasized in your presentation, that even a fairly aware person about patient safety like me is reluctant or hesitant to take a decision when it comes to the life of a loved one. So even if you create awareness about patient safety, it is going to take a little time for us to get into that mode. So is there any possibility, any decisions that can be taken at the top management level in hospitals which would facilitate this process for patient safety?
Certainly top management of hospitals or institutes can shall we say, help the doctor and help the patient. But you see, you can, in whichever sector you are in any service industry, there is a certain amount of information which can be provided. But finally, the decision has to be taken by you. I cannot take what you're talking about. We can go that extra mile, but finally you have to take a decision. You are the consumer. We can only facilitate. We cannot take the decision for you. Things have changed now, and due to multiple reasons. We cannot foist the decision on you. We can take you to 90%, but then finally you have to take the decision at any level. Alright? Okay, I think we will be breaking for tea. The next session was starting at 11:50 a.m. Now, you could probably have, instead of 5 minutes, maybe 10 minutes for tea, if that is permissible, but the next session, I think, would have to start at 11:55 a.m. instead of 11:50 a.m. We'll give you 5 minutes extra for the tea. I think we will be then still 5 minutes behind schedule, but we will try to recover.
provoking, enlightening discussion.